on the extremes of age, the pediatric and geriatric patient, and some of the special considerations as trauma in the pregnant patient. So our presenter is going to be Kim Gorman, who's one of the nurse practitioners on the trauma service and is actually the lead for our geriatric trauma certification, which we're pursuing right now. You're on.
I guess I should hurry up.
You can just advance with these right here.
All right.
There we go.
I guess I'll let you see my smile. I'll take away this mask. So today we're going to talk about all kinds of considerations with our patients with extremes of aging and also the pregnancy patient. As we go through, we're going to identify some of the differences that we have. When we're talking about the pediatric patient, we're going to review the epidemiology and common mechanisms of injury. We're going to understand the basic anatomy and physiology and response to injury as it refers to the pediatric patient, because they are not just a small adult, they have some different anatomy and physiology that goes along with their injury. We're also going to look at appropriate age care that we are going to provide at our facilities and anticipate and avoid the pitfalls that come along with this pediatric patient. So when we're looking at the pediatric trauma, when we look in this picture, the first thing that you probably notice is that the patient or the person does not have any protective equipment on. And it's not always the height that the person falls from, but it's the way that they fall and hit their head. And you notice right off the bat, this young child does not have a helmet. So he's at a high risk for traumatic brain injury if he was to fall, not to mention broken bones if he was to fall and get stepped on by the horse. So when we're talking about the epidemiology, injury is the most common cause of death and disability in our pediatric patients. There is multi-system injury that is common in this population. And some of the most common mechanisms are multi-motor vehicle crash or collision. And it could be the person was an occupant in the vehicle, they could be the pedestrian running across the street and the car doesn't see them. It could be the little kid was riding their bicycle and again went out in front of the car and they were hit, or ATV accidents. Drowning is common, especially in the summertime when the kids are out just running, they're out just swimming, they're swimming for long periods of time, and they're having a good time and don't realize that they're getting tired and can end up drowning. And then we also have the burns and inhalation injuries that Dr. Sleet just went over, some of the burns and inhalation, and we're going to go through some of those topics as well during this talk. The thing that we don't like to hear about most is homicide, including child abuse, which is prevalent not only in this area, but also other areas. And anywhere that you have a large conglomerate of children, you have to suspect that there could be some child abuse. And falls, as we mentioned, could be an injury mechanism that happens with children that we want to evaluate all the risks for fractures or injuries associated with the fall. When we're talking about age-appropriate equipment, the Broslow tape is the thing that comes to mind for most people as soon as they hear a pediatric patient. When you know that you have a pediatric patient coming, that's the first thing that you should have out and available so that you could lay it alongside of the patient so you can measure the child's length, and then that estimates their weight and gives you the size of the NG tube, the ET tube, and the urinary catheter. It also gives you the medication dosages, which are appropriate for that child's size for rapid sequence intubation and medications like that come out of the pediatric cart. When you use the Broslow tape, it's color-coded. So the color coding on the tape itself will tell you which drawer to open. That drawer contains all the equipment that you need for that pediatric patient. What you need to make sure is if you don't have a lot of pediatric patients that come through, that your pediatric cart is always up to date and has the proper equipment. There are a lot of online resources and apps that you can use. There's a PediStat app that you can download on most Android or Apple devices. If you have a smartphone, you can go and search for any of these devices that can help you to care for the pediatric patient. but make sure that you always use the Broslow tape when you have that patient that comes in. So the big thing that you need to look at in your center is what do you have available for a pediatric patient? Do you have the pediatric size endotubes or urinary catheters or even chest tubes to be able to take care of a small child on up to a small adult? You need to know where that's all located. So it's not good enough just to have the equipment there, but you have to be familiar with what you have and be familiar with where it's at, because the same person is not going to be available at all times during that pediatric trauma that comes in. So making sure that everybody is aware of where all the equipment is important as well. And if you don't use this equipment often, it's important for you to go through some additional education and training for all of the staff to make sure that everybody knows and can operate that equipment. When we talk about pediatric airway, they do have a unique anatomy. They have a large tongue and their tonsils that are large that can obstruct the view. So your intubation could be difficult to be able to get the tube down through appropriately. When we look at their airway, it's short, narrow, and funnel shaped, and they have an anterior larynx in which, and they also have a short trachea. They want to use a straight blade when you're intubating a pediatric patient. A lot of people call it a Miller blade, and it's how you can pull the all the tissue out of the way so that you can see the airway and the vocal cords in order to intubate the pediatric patient. Becoming familiar with the different types of blades and the sizes of blades that you have is important, especially if you don't have pediatric patients that often. When we're talking about anatomy for the airway, the cricoid is the narrowest portion of the airway. You have a smaller endotracheal tubes, which is all based on that Broslow tape. In the age under 12, we don't do a surgical cricothyroidotomy, and that's because of the risk for injury for that patient, in addition to the anatomy that the pediatric patient has. So what is an option is a needle cricothyroidotomy if you need to do that for the pediatric patient. As I mentioned before, they do have a short trachea, so they have the risk of right mainstem intubation. So you have to be aware of the patient's anatomy when you're going to intubate. When you're looking at the picture on the screen, you can see the comparison of the endotube size and the size of the child's fifth finger when you're comparing the size to intubate the patient with. But again, the Broslow tape is what would be what you're using to choose that tube size. When we're talking about immobilization for the pediatric patient, remember that the pediatric patient has a larger head in comparison to their torso. So it's most appropriate to place a padding from the neck on down to the feet that allows the neck to straighten or keep the neutral cervical spine. So you don't want the pediatric patient into a sniffing position. So the padding is important for this type of patient, and you want to have a properly sized backboard or padding if that's what you're using. When we talk about breathing, hypoxia is the most common cause of cardiac arrest, oxygen, and airway. So when we're looking at the pediatric patient that came in as a choking patient, they're having difficulty with breathing. That difficulty with breathing and the lack of oxygen is what's going to cause that patient to go into a cardiac arrest. So you need to improve the way the patient is breathing, improve the oxygenation for the pediatric patient, which will stifle off the effects of possibly going into a cardiac arrest. Some of those common chest trauma injuries, there are common chest injuries, but rib fractures are less likely. And the rib fractures are more compliant, their chest wall is more compliant, and their mediastinum is mobile somewhat. So if you have a pediatric patient that has rib fractures, you have to be concerned for some type of strong force that caused the ribs to fracture. A tension pneumothorax or underlying pulmonary contusion is more likely with a pediatric patient because of the way the ribs and their chest wall is formed. The chest tubes are smaller, but the placement site is the same in children and as in adults. So your procedure would be the same for the chest tube insertion. When we're talking about pediatric circulation, looking at shock recognition, so we already mentioned that pediatrics patients have a different in their pathophysiology as well as their organs, size, and the amount of blood that's in their body, but they also have an increased physiologic reserve that maintains a systolic blood pressure even in a shock state. So that patient can go longer, a pediatric patient can go longer before they kind of go off the edge. And when they go off the edge, their blood pressure is going to drop, their heart rate's going to drop, and they're going to deteriorate very quickly. So you have to recognize shock in a pediatric patient from the start so that you can get ahead of the shock and improve that patient's outcome. If you're looking at the physiologic impact on the hemodynamic changes, that solid purple line that's in the middle is your blood pressure. And you can see where the blood pressure goes straight across until it all of a sudden drops down at the mark of 30% of your blood loss. When you're looking at the heart rate, your heart rate will slowly climb up, and it's going to take longer for your heart rate to hit that pivotal point, but when it hits that high heart rate, it's going to rapidly decrease. And when you're looking at the cardiac output, which is your dotted line on the bottom, you can see that your cardiac output goes pretty much along with your blood pressure, but then it significantly starts to drop off as your blood pressure drops off as well. So recognition of shock in the pediatric patient is important. When we're looking at the age-specific vital signs, it's all listed out here for you by age group. When we're looking at the 0 to 2-year-old age group, the heart rate is 150 to 160. So when you have that patient that comes in that's a 1.5-year-old, and you see that they have a high heart rate, that's normal in that age group. It would be more concerning if the heart rate was extreme high or extreme low for that age group. When you're looking at the 6 to 12 years old, I remember that one the easiest for me, because the cap is 120, 12 years is 120. And you're going for a range between 100 and 120. You're 3 to 5 years old. I picked the 140, which is in between the 3 and 5. So the heart rate is that's how I remember the heart rate and for the pediatric patient. When we're looking at systolic blood pressures, we're looking at lower systolic blood pressures, especially in the 0 to 2 years category. We're looking at 60 to 70 as their systolic blood pressure. Their respiratory rate is also higher in the younger age group, so 40 to 60 could be normal for that patient. The 6 to 12 years old, you want them to be less than 30. But you're not looking at one number in particular. You're looking at the patient themselves, their mechanism of injury, the fact that they could have a potential life-threatening injury, and then combining all of those vital signs to evaluate the patient. When we're looking at pediatric circulation, their venous access is the same as the adult. So just as we would when an adult trauma patient comes in, we look for peripheral IV site. We look for 2 large bore IVs. That's what we want to do for our pediatric patient as well. We could use an interosseous access for the pediatric patient, and we do know that all IV fluids can go through an interosseous. However, we would prefer to have the peripheral IV sites in the upper extremities if we can. There are cut down methods that can be used or central lines that can be used, but those are for specific criteria and for people who are have the skills to be able to perform those procedures, and those are not the preferred method. But it is an option if you don't have any other way of getting access for these patients. For circulation, the treatment of shock, the first thing I believe Dr. Morrissey talked about is stopping the bleeding. And that has come a long way, trying to make sure that we're stopping the bleed before we lose too much blood. So that's starting out in the field With any bleeding site, you're applying pressure, and if you need to, then you would apply a tourniquet. If we are bleeding, we can bolus with 20 mLs per kilogram of warmed LR or normal saline, and you can do that times 2. But we do know that the criteria is changing, and Dr. Dumeier talked about the fact that we want to begin blood transfusions early, especially in a hemodynamically unstable patient and the person who is bleeding. So for the pediatric patient, we would be doing transfusions of blood with 10 mLs per kilogram. When we're looking at this picture, you can see that this patient has a splenic laceration with active arterial extravasation and a hemoperitoneum. This is a 16-year-old boy who was in a motor vehicle collision. Now, you're not going to be able to recognize that out in the field, except for by the mechanism of injury, if they had a seatbelt sign, or the mechanism where he went over the handlebars. Those are the kind of things that are going to lead you to the fact that this patient may have a splenic laceration. So for this patient, getting them to the trauma center or to care to be able to evaluate the patient is important. But recognizing that stopping the bleeding and doing blood transfusion or maintaining blood pressure is important. Resuscitation endpoints. So what we're looking for, I already said that we don't necessarily just go by those vital signs. They are a guide marker, and not every patient fits into those categories. And we don't always know the patient's background as to whether or not they have comorbidities. So what you're looking for is their mentation improving? And if their Glasgow Coma score was maybe 13 or 14 and they're back up to a 15, then you know that you're doing a little bit better. We're looking at their skin color and their temperature of their skin. We're looking at capillary refill. We're looking at their heart rate to make sure that the heart rate is stabilizing. We're looking at their blood pressure, but not as just one measurement. We're looking at overall the improvement of the blood pressure. And then we're also looking at urinary output to make sure that the patient is maintaining a good urinary output to know that we're perfusing all of the vital organs. When we're looking at disability and central nervous injuries, we're looking to prevent secondary brain injury by restoring the circulating volume and avoiding hypoxemia. Those are the two biggest indicators with any traumatic brain injury, whether you're a child or adult, that could ensure or help to eliminate, I should say, the secondary injury. Once you have a traumatic brain injury and you're not perfusing the brain to a point where they're getting good enough blood volume, or you're not providing the brain with the oxygen that it needs, then they're going to have a secondary injury. Each time that patient has a blood pressure that drops below the threshold or has a oxygen saturation that drops below the threshold, they're going to have a secondary brain injury that causes that patient to go into further traumatic brain injury and decreases their chance of survival. And that being said, our children have a better prognosis than adults for the similar injuries. However, we still have to be aggressive with their care, recognizing it early and making sure that we maintain their blood pressure and oxygenation. When we're talking about exposure and environment, it's important to completely undress the child, making sure that the room is heated up adequately, and we're anticipating and preventing hypothermia. So some of the ways that we can do that, especially at this time of the year, is to make sure that we avoid heat loss. These kids have a big head, so making sure that they keep a hat on their head when they go outside, covering up all their uncovered skin, so making sure that they wear mittens, and also avoiding getting wet. So multiple layers of clothing for children when they go outside is important, especially when they're playing in the snow, to avoid hypothermia or hypothermia injuries. When we do have the patient that comes in and they're hypothermic, we're going to actively rewarm the patient to make sure that we're avoiding injuries. Non-accidental traumas for the pediatric patient. This is a developmentally delayed 6-year-old. His mother reports that she found him sitting in the hot water in the bathtub. So when you see this scenario, or when this patient comes in, the first thing that should come to your mind is, I have a 6-year-old who is developmentally delayed, and he got into the bathtub by himself in scalding water and sat. When you're looking at the injuries, you can see across the buttocks that was not fully submerged in the water, but you can see that possibly he was dipped into the scalding hot water. So when you start looking at the history, when you're asking the parents questions about how this occurred, you're looking for discrepancies. Did they start out with one portion of the story and then started to change the details? Or is it the fact that this child is developmentally delayed, and the fact that he could not get into the tub by himself and pour himself a scalding hot tub of water? All those kind of things play into the fact that, is this a child abuse victim, and do you want to investigate further? In addition to that, when you're looking at the physical exam, you're looking at the pattern of the injuries, the patterns of the blisters for this patient, but you're also looking for injuries that identify that maybe there has been abuse that has been ongoing. It's the child that comes in every other week with a different type of injury, with a different type of story. It's the child who has multiple bruises on them that is suggestive that he has varying stages of bruising and possibly being injured from abuse. Is it the fact that he has round circular burns on his arms or legs, mostly on the inner thighs or areas where you can't necessarily see, that suspect that this child is being abused? Those are the things that you have to look at, and you have to start questioning on these patients. And it's always important to report any type of abuse that you suspect, to make sure that there's not ongoing abuse occurring. That's also important to take off all the clothes so you can investigate and evaluate the skin for these children. So some of the pediatric pitfalls is the lack of age-appropriate equipment. I mentioned early on in this talk that making sure that whatever center you have, the ability that you have to take care of that pediatric patient when they first come in until you get them to a definitive care, you need to make sure that you have the appropriate equipment. So the first thing that you do is you go back into your ER triage area, you look and see what equipment that you have. Make sure that you have the Broslow tape and all the equipment that you need to take care of that patient. And someone should be taking responsibility of that to make sure that the equipment is there at all times. Failure to understand the unique anatomy and physiology of the pediatric patient. They're not just a small adult. They do have a lot of the same physiology that we have, but sometimes they can go a little bit longer before they actually crash. And that's the thing that you have to recognize. Appropriate blood pressure on a patient that's 3 years old now may not be appropriate in 10 minutes because you didn't recognize that they had sepsis or shock going on. Allowing the pediatric patient to become hypoxic or hypothermic is also some of the pitfalls. We need to make sure that we're maintaining their oxygenation and maintaining a warm environment for them. Because of their thin skin, they can lose their heat very quickly. So this is where we have questions. Okay.
To the next slide.
I have it. The Broslow tape. A is used to secure an endotracheal tube. B is a special adhesive used to secure cricothyroidotomy tube. C is used to determine pediatric drug dosing. And D used to assure inline stabilization of the neck for intubation.
Okay, we'll end the question there. Go ahead and talk about the results.
Okay, so a majority of the people chose that that's used to determine pediatric drug dosing, and that is the correct answer. Broslow tape is what is used to lay aside of the pediatric trauma patient so that you can very easily get the drug dosaging, the endotube size, as well as all the equipment that you would need out of that appropriately colored drawer. Okay, a 6-year-old boy crashed his ATV 30 miles in the backcountry while hunting with his 17-year-old brother. Rescue attempts were delayed because of cold rain that made the trails muddy and difficult to traverse. When the patient arrives at your Royal 20-bed facility, his temperature is 32 degrees Celsius. His heart rate is 160. His blood pressure is 80/40, and he has respiratory rate of 32. His Glasgow Coma score is 13, and he is crying loudly with equal breath sounds. The preferred method for vascular access in this pediatric patient is A, intraosseous placement in the tibia, B, venous cut down at the ankle, C, intraosseous placement in the mediastinum, D, percutaneous peripheral in the antecubital fossa. Okay, we're going to go ahead and close out that polling. The answer is D, percutaneous peripheral in the antecubital fossa is a preferred method. We're looking for 2 large bore in the upper extremities, which would be the antecubital fossa. Intraosseous placement is not the preferred method, but it is a method that can be used in a patient who you are unable to get IV access in. A 4-year-old child presents with hypotension after a motor vehicle crash. Vascular access has been obtained. Initial fluid resuscitation should be administered with A, 20 milliliters per kilogram bolus of Ringer's lactate. B, IV fluid is not given to injured children. C, 10 mLs per kilogram bolus of quarter normal saline with 20 milliequivalents of KCl. Or D, 100 mLs per kg bolus of normal saline. Okay, you can go ahead and close it out, Mike. The 20 ml per kg bolus of lactated Ringers, which is the answer A. There was some 10 mLs per kg bolus of the quarter normal saline, which may have been confusing because the blood products is 10 mLs per kg. The 100 mLs per kg bolus of normal saline in the pediatric patient may be too much depending on the patient themselves and their size. But the right answer is 20 mLs per kg.
So what do we got here?
Hi, Dr. Dumar. We have a 10-year-old that was riding his ATV, unhelmeted, and he wrecked his ATV. He is, eyes are open, not really responsive, agonal breathing, respiration's around 28. We just got him hooked up to the oxygen. Okay. His heart rate's 88. His saturation is 97% with a blood pressure of 138/96.
Okay.
His respirations when he first came in were about 28.
Okay. So 10-year-old, previously healthy, ATV accident, doesn't seem to be following me or gazing. Really don't think he's breathing too well. So can you give me the pediatric bag valve? Oh, Jay, just give me this right here first. And I'm going to go ahead and just assisted ventilation.
Is it okay if I put a collar in place?
Yeah, let's get a collar on him. And Jody, if you would get the give me the Breslow tape.
I already have it out, Dr. Mark.
And the card. And this one's going to come out.
I'll get the card.
He is breathing, but he's just not protecting his airways. So, Kim, if you can just put that collar on and then just hold this oxygen with your hands one way, measure him. Okay. And again, this is a Breslow tape. The only issue here is you need to make sure that it says measure from here is at his head. Okay. So I'm going to basically measure from his head to his toes, his feet, and he falls into the blue range here. And basically that gives me all the medications, dosages, and equipment sizes for a child his age. So Jody went to the Breslow cart, opened up the blue drawer, and when you pull that drawer out, it has all the appropriate medications. This child is basically unresponsive, and we're easily bag valve masking him. His oxygenation is okay, so I'm just going to go right to intubation. So we've got the laryngoscope, the appropriate size endotracheal tube, and then we'll intubate him and continue down the survey from here.